welcome to our HIV Center Grand Rounds. And we're really thrilled today with the presentation that we're having. Let me announce our upcoming rounds on March 20th. We have Dr. Lawrence Yang. Dr. Lawrence Yang, we're still working on the title. It will be on Zoom. It will not be hybrid. So that's March 20th, Dr. Lawrence Yang. Okay, well, we have two people presenting today, and one is present here in the room. The other one is remote. And let me introduce each of them very quickly, and then I'll pause and see if this alarm is happening or not. So the first one up, I think, Victoria, you'll be first? Yeah, will be Dr. Victoria Frye, known by many of us for many years, is a professor of the Columbia School of Social Work, trained in epidemiology and social science theory and methods. Her work seeks to reduce health inequity through research with a focus on two health and social problems, HIV and interpersonal problems. Additionally, her work includes developing complex theory-based conceptual models, specifying interconnected macro, meso, and micro level pathways, which she tests using observational data and multi-level statistical models. And then we have joining us via Zoom would be Dr. Meruyert Darisheva, an epidemiologist and project director at the Global Health Research Center of Central Asia at Columbia University. That's based in Almaty, Kazakhstan, which I've been to. It's a wonderful center. Her research focuses on multi-level factors associated with TB and HIV, as well as the design and testing of behavioral interventions to improve access to HIV care for vulnerable and marginalized groups of people, including people who exchange sex, sex for money and goods, people who use drugs, and people living with HIV. So those are our duo presenters. And I'm wondering if we should get started. Maybe the fire drill is not happening. So everyone online, know that there may be an interruption. You may hear whistles and bells, and we'll have to pause. But right now, I'm going to turn it over to Victoria. Thank you.
Thank you so much. Thanks for those of you who have shown up today in person. It's really deeply appreciated. Thank you to everyone online who has joined us, and especially colleagues around the world who are disrupting their evening schedules or other schedules to be here. Again, today with Dr. Darisheva, we will be presenting on AEGIDA, which is an intervention to support HIV testing via self-testing and stigma management among women who exchange sex and or use substances in Kazakhstan. I want to start by acknowledging, first I want to acknowledge that I'm standing on the land of unceded territory of indigenous groups here in the United States. This work occurred though in Kazakhstan. So we want to first thank all of the women who gave their time and energy to inform the design and testing of AEGIDA. We want to thank our dedicated outreach workers and others who are part of the community organizations who are co-authors on this paper and presentation, and very well may be out there in the audience or and would be available for questions at the end. Amelia and community friends. We also want to thank the dedicated healthcare providers, public health leaders, and the research workers at the Kazakh Scientific Center for Dermatology and Infectious Diseases, as well as, of course, our Global Health Research Center of Central Asia team members. I want to make sure, I'm just going to check in with Dr. Darisheva and make sure that what I'm showing is the correct set of slides. Because I did notice a change that I had made and I don't see it here, but let's see. I may ask to swap it out in a minute if it's not, but sorry. And I do want to acknowledge that this study was funded by NIDA to MPI's Dr. Frye, that's me, and Dr. Nabila Elbasell, who is the director of the Social Intervention Group and a university professor at Columbia University, and the Social Intervention Group is at the School of Social Work. This is our US-based team. There's me, Dr. Elbasell, Dr. Bruck West, who I worked Dr. Darisheva and I worked extremely closely with to design and test this intervention. Dr. Laura Starbird, who led the costing effort, and Tara McCrimmon and Olivia Cordingley, who are basically performed at the level of co-investigators and are training in their doctoral programs in public health and social work, respectively. I'll turn it over to Dr. Darisheva to introduce the Kazakh team.
Thank you, Victoria. I present our Kazakhstani team, Dr. Baurjan Bayserkin, Kazakh Scientific Center of Dermatology and Infectious Diseases under Ministry of Health. Kazakh Scientific Center of Dermatology and Infectious Disease is an organization which is responsible for developing and implementing the national strategy and policy for HIV treatment and prevention. Asel Terlikbayeva, Regional Director at Global Health Research Center of Central Asia, Sholpan Primbetova, Deputy Regional Director at Global Health Research Center, me, Meruyert Darisheva, Project Director, and our community partners, advocates working with women affected by HIV, Natalia Zholnerova and Ekaterina Grigorchuk.
Thank you. Okay, so what we'll be talking about today is we'll give a little bit of background, we'll do a study overview and describe the formative research that informed the development of the AEGIDA intervention, or the active arm of our study. We'll talk about the intervention structure and function. We'll talk about study implementation, because this was a complex study with a lot of different moving parts and working with a very vulnerable and marginalized group of people. We'll present the results, of course, the process evaluation, a little bit on costing results, and talk about some of our conclusions. And to start the background on Kazakhstan, Dr. Darisheva will take us through these next few slides.
The study was conducted in Kazakhstan, Almaty city. Kazakhstan is one of the Central Asian countries which classified as an upper middle income country. It borders Russia, China, Kyrgyzstan, Uzbekistan, Turkmenistan with a coastline along the Caspian Sea. Kazakhstan was a part of Soviet Union and declared its independence in 1991. The population in Kazakhstan is around 20.3 million with a median age 29.7 years. Kazakhstan is a multi-ethnic country where ethnic Kazakhs are about 71%, Russians are about 15%, Uzbek 3%, Ukrainians 2%, Uyghur 1.5%, and other nationalities like Germans, Tatars, Azerbaijanis, Koreans is less than 1%.
Thank you.
Yeah. So Almaty belongs to a region with a high level of HIV prevalence compared to the national average, and accounted for 18% of all new HIV cases registered in Kazakhstan. And heterosexual transmission accounted made up of 69% of new HIV cases. This represents a shift from 2005, when injection drug use was the largest proportion, around 66% of all new cases.
So before we begin describing the study in more detail, we want to provide some background. So when AEGIDA launched in 2021, HIV self-testing was not widely available in Kazakhstan, either commercially or through governmental programming. Although there was a demonstration project underway, it was focused on gay and bisexual men. And as well, it's important to note that biomedical HIV prevention, PrEP, scale-up only began in 2021, again focused primarily on MSM, or gay and bisexual men. More recently, things have changed, of course, since then. The Kazakh National Plan included PrEP in 2021, but again was really focused on some key populations, not women broadly, and not necessarily women who exchange sex. We all know, of course, that biomedical prevention is a cornerstone of our approach to HIV epidemic control. And of course, HIV testing is the gateway to biomedical prevention, as well as prevention through treatment. So HIV self-testing has been identified as a way to increase consistent testing, and it has been shown to increase HIV testing as well as linkage to care in some contexts, among multiple populations and key populations, including some among women who have women who exchange sex. And it is important at this point to also note that HIV self-testing, there were concerns about it when it began being introduced in the United States in 2012 and other areas. There were concerns around whether people would be able to do the test properly, whether if they received positive results, if they would have an extreme negative psychological response. And so this is the context for HIV self-testing as part of HIV prevention. So from this background and from this context, we partnered with advocates for sex workers and women who exchange sex for needed resources to adapt an evidence-based intervention called TRUST, which was developed in the United States for gay, bisexual, same-gender loving, and other men who have sex with men. And that was led by me and Dr. Leo Wilton at Binghamton University. I think we might have presented that here at some point. And so we adapted that to create AEGIDA. So the goal of AEGIDA, the intervention, was to increase consistent HIV testing and access to biomedical prevention and treatment among women who exchange sex for needed resources and use substances, again, in Kazakhstan. So our goal was to leverage HIV self-testing as an autonomy-enhancing, user-controlled, and private, thus stigma-avoiding, that's, I think, important to note, method of increasing status knowledge via any testing method. So the goal is to use HST to increase testing, period, with the added benefit that we know that when we learn our status, we will change our sexual behavior in response, one way or another. Typically, though, there's good evidence that with positive results, we reduce non-barrier sex or pickup prevention methods. Stigma was also addressed in AEGIDA as a barrier to all types of testing, and so we adopted social cognitive and empowerment approaches to address that as well. So what were our specific aims? We had 3 aims. We wanted to elicit preferences to inform the adaptation of trust. We wanted to design, component test, and pre-pilot what turned out to be a 4-session intervention. We wanted to assess the feasibility, acceptability, and determine the preliminary efficacy. So this was a pilot RCT. It was an R34. This was not a fully powered R01 RCT. So we conducted a 90-person trial. We randomized 90 HIV-negative women to the 4-session active arm and or a time and attention control arm in a 2-to-1 ratio and followed them for 6 months. So our primary outcomes are past 3 months testing, frequent testing, linkage to care, and PrEP knowledge. Secondary outcomes, which we cannot present today, and we'll describe why, or will not, include incident biologically confirmed STIs, as well as stigma-related factors. And as an exploratory aim, we wanted to describe the cost and the implications for feasibility and sustainability. Okay. So our study had 3 phases. There was the formative research phase where we did in-depth interviews with women who exchange sex and use substances, as well as focus groups. In phase 2, we tailored and component tested and pre-piloted the intervention. In phase 3, we had the 90-person RCT, and then of course we have our study outcomes. I just want to note that our formative phase occurred in March to July of 2021. And our pilot RCT started in November of 2022 and ended in November 2023. I also should note that during this time, we were obviously affected by COVID, as well as political instability in Kazakhstan in January of, I believe, 2021. And I want to make sure that's correct. I don't know.
Yes.
Thank you. Thank you, Meruyert. And I think this might be where you pick up. I don't have my notes, so I can't tell where we're supposed to tag team.
Yes, sure. So we conducted at first stage formative research. We did narrative literature review to identify barriers and facilitators to HIV testing and HIV self-testing among women who exchange sex. We did qualitative in-depth interviews and focus groups exploring HCT preferences, barriers, facilitators among women. So I think Victoria already mentioned that we did recruitment in March. In July in Almaty and Taldykurgan. Participants met the following eligibility criteria: exchange sex in the past 90 days, use drugs in the past year, condomless sex with male partner in the past 90 days, read, speak Russian. Representatives from local nonprofit sex worker advocacy organization recruited and interviewed participants using snowball sampling.
So I'll pick up here and just sort of go a little bit, go quickly through these. So we did the 30 in-depth interviews and the focus groups. We had 48 participants together. We also have conducted brief surveys. And of course, we use just descriptive data analysis for the surveys. We use the framework method for pragmatic analysis of the qualitative data to identify key themes and to answer our pragmatic questions. Everything was transcribed, translated, and then we used deduce to do the coding and analysis. In terms of our formative sample, you can see here the mean age was about 30. About half were Kazakh ethnicity, with about 30% being Russian ethnicity, 60% or had a vocational degree or higher. Over 2/3 did not have a main partner. 90% said that sex work was their main income, and just 16% used condoms all of the time. And again, context here, there was no PrEP for women at the time. So condom use is the primary barrier form of protection from HIV. 80% used alcohol and drugs before sex with paying partners, and 42% experienced partner violence with a main partner in the past 3 months. All reported lifetime HIV testing, but just almost 2/3 reported HIV testing in the past 6 months. And now I'll turn it over to Dr. Darisheva.
During formative research, we also explored participants' access to healthcare services, attitude toward HIV testing and HIV self-testing. For example, for question, where do participants access healthcare services, we found that significant proportion of the sample don't have access, 30.7%. Receive services at state polyclinics, 50%, at private clinics, 19%. Main barriers are cost, registration process, wait time in clinics, and stigma. Here we present some quotes from interviews. Sex worker status really hinders. The attitude is generally extremely bad, and it means that if you inject drugs, provide some type of services, you are rubbish. Please, next slide. We asked question, why do participants get tested? And main reasons were to monitor health status given type of work, and on occasion such as condom breakage. Most participants received HIV testing in HIV clinics and friendly cabinets, if you can see on the blue pie. 95% participants believe that they should get tested at least once a year, and 44% of them had been tested in the past 3 months. We also explored how participants experience stigma while testing. Participants described general context of stigma and discrimination. I don't believe that doctors can hide it all and not tell anyone. It will pop up somewhere anyway, and someone will tell someone. Therefore, maybe people are afraid. We are afraid to go to such places in general. We don't go to hospitals. Another quote, in Kazakhstan, if you get sick, there is still not enough support. The state will still keep us separate and look with disgust. Yes, they're afraid that they will be separated. We asked how do participants communicate about testing. Most participants say that they don't discuss HIV testing with their colleagues. We never discuss it. I don't want to raise this conversation first. Then she can tell my clients she did the test. Participants have a positive attitude toward HIV testing, but not at the fear of what a positive result would mean for their work, income, and their lives. 95, next slide, please.
Sorry.
Yeah. 95% would like to be trained to use HCT, want to learn effectiveness of HCT, to be confident in result, be incentivized to test, learn how to manage positive results, and be supported in results. Prefer to be trained by experts, professionals, and individually, not in groups. Reasons for not wanting to be trained: prefer to be tested by a medical professional or prefer to learn it on their own. And we also asked about preferred access to HCT, and it was pharmacy and aid centers friendly cabinet, and less participants wanted to access tests at polyclinics and NGO. Almost 70% of participants wanted to be trained online, through WhatsApp and video. For example, well, it will be easier through WhatsApp and video since I work the whole day. I can see if you send me something, right? So we found a number of vulnerabilities to HIV acquisition. Considerable proportion of respondents were tested more than a year prior to the formative phase. Fear of HIV testing due to anxiety of losing job and income, stigma and discrimination at the testing sites. Women who exchange sex have a strong interest in self-test, PrEP, and HCT training. Preferred training element included training trained by professionals, HCT practice, management of positive results, having both online and in-person options, being trained individually, not in groups.
So we took these, so the next slides will go over the study design, the intervention content, structure, and function. So we took these results and we developed the intervention, the active arm AEGIDA, which we'll describe in a moment, for the pilot RCT. So the pilot RCT is a pretty traditional design. We had eligibility criteria, inclusion and exclusion criteria. Of course, you had to fall into the group of people who would benefit from this kind of an intervention. I won't go through all of this, but we did have some exclusion criteria. So if you, during the consent process, were not able to understand what we were talking about, would not be included for obvious reasons, not able to give consent then. Understanding and speaking in Russian at a basic level was important, willing to complete the study, and not enrolled in our phase 2 of the study. We had a time and attention control, and we had follow-up for 6 months, and we did assessments at 3 and 6 months. So these are our primary outcomes. So recent HIV testing, reporting testing HIV test once in the past 3 months, as well as consistent testing defined as at least one HIV test every 3 months over the follow-up 6-month follow-up period. So this is the recommendation, right? That we get tested every 3 months, not once a year, not even necessarily every 6 months will be enough. And then linkage to confirmatory testing and care, and for people who tested positive, and I'll just say right now, we did not have anyone who tested positive who reported that to us, and knowledge of PrEP for HIV prevention. I want to say a few things about participant safety. It came up in the qualitative formative research that women were, of course, concerned about the negative impact of a positive test result on their lives, their livelihood, as well as the potential for violence if violent male partners or other partners found out. So we really centered safety issues throughout at each step of the pilot RCT, from screening to enrollment to attendance at the sessions, as well as taking an HIV self-test kit with you or to come and get one, or to get it in any fashion. So facilitators who were experienced professional facilitators, many of whom have been working at Gersha for 10 plus years, they were trained to be especially sensitive to this issue. Where HIV test kits were provided and stored was discussed in terms of safety planning, and this in the sessions and follow-up planning, again, explored the potential adverse impact on relationships with partners and family. And again, all staff were experienced professionals, trained in the protocol, and were used to adherence and research with people who experienced partner violence. So a lot of the SIG and Gersha studies have focused on partner violence. So just, you know, very, very important when we're talking about HIV self-testing with a vulnerable group of people. Okay, so how did we design the active arm, what we call the AEGIDA arm, or what we call AEGIDA? So we applied modified intervention mapping. We designed a 4-session hybrid in-person and video conference or phone-based intervention with an Instagram support page. And sessions were, as we developed them, we worked closely with our advocacy partners. They reviewed all of the sessions, provided us feedback. We pilot tested it with 5 participants. Again, we got facilitator and participant feedback, edited the manuals, revised the manuals, did some more, you know, so it was an iterative process, finalized the manuals, and conducted a refresher training before the launch. So theoretically, what was our intervention informed by? 4 primary theoretical approaches: social cognitive theory, empowerment or self-determination theory, stigma, and social and peer support. So in terms of from each of these theoretical domains, what do we focus on? For our paper, we have these sort of lined up with these acronyms. I know you're all familiar with this, but I do want to emphasize that it was heavily theory-based. So, we focused a lot in the first session, for example, and I'll walk through the sessions pretty briefly, on raising awareness. A lot of people did not know about HIV self-testing as an option, were potentially worried about their ability to do the test. Of course, fear of the test result, and that applied to not just HST, but any kind of testing. So there was a lot of time spent, particularly in the first session, on training on how to do HST to increase feelings of self-efficacy and skills and mastery over doing it, as well as focusing on it as part of self-care and self-screening more broadly. There were a lot of, we didn't present a lot of the information and the analysis on stigma from the formative phase, but there was a high level of internalized as well as layered stigma and a significant amount of anticipated stigma from healthcare providers. So addressing self-stigma was an entire session. And that was, of course, in response to the high level of community stigma that exists. There was a sense of low perceived peer support for testing. So we addressed this through a peer education component that was focused primarily on increasing feelings of self-efficacy and ability to do the test and train other people, but also could have a secondary benefit of increasing social support among the sex worker or women who exchange sex communities or peer networks. So in terms of SCT, we were really focused on awareness and knowledge, outcome expectancy, self-efficacy, and skills. For empowerment, we were hoping that all of this would increase feelings of autonomy, feelings of control and empowerment. Again, talked a little bit about increasing feelings of connectedness to social support and peers. And the stigma component was really addressing self-stigma as well as how to cope with stigma. And I do want to note, HST is kind of kicks the stigma can down the road in contexts like this, but it has benefits for the individual and potentially their partners, even if they don't get confirmed and they don't register as someone living with HIV in the country, which is the required process. So it is not a stigma solving technology. It's actually can be a stigma avoidant or a way of coping. So these are the sessions, just in terms of what the, how the facilitators made sure they were doing what we hoped they would do. So in the first session, it was focused entirely on basic HIV education and risk reduction, as well as HIV self-testing, skills, and practice. And I'll show you a video in a moment of what one of our co-investigators and co-authors on the paper, who is the head of Amelia, did a wonderful video. It's in Russian, so unless you speak Russian, you won't be able to understand it, but I hope we might have the closed captions on, I'm not sure. And we also introduced a metaphor, which we used throughout, which is the idea of we are all plants, we are all flowers, we are all trying to grow and thrive. And the environment that we're in is very much determines and either supports or acts as a barrier to this. And so this sort of flowed throughout our intervention. At every session, folks were offered things that they were able to take back with them. This was the first session, it was in person. The second session focused primarily on peer education. So we checked in about whether they practiced with the HIV self-test kit that they took home. So this is a video or telephone delivered, if the video wasn't working, session. Again, we sort of talked about HST as a form of self-care and empowering and built motivation for engaging in it, and then began to talk about peer education. Is this something that you would be interested in educating your peers about? What are some of the barriers that you think would be there for you to talk to your peers, friends, family members about HIV self-testing? There was a role play where they practiced approaching someone about telling them and educating them on HIV self-testing. Again, building motivation throughout. So motivational interviewing was one of the, techniques that we used in every session, as everybody does, because it's so effective. We talked about handling test results, and this was really where we also began to get into the concerns around getting positive test results, either for a friend or for yourself. Oftentimes we find it's easier to talk about what would happen to a friend, and we have a lot more compassion for our friends than we do sometimes for ourselves. So it's a nice way of changing perspectives, for the participant in order to then bring it back to themselves in terms of, okay, well, if your friend got this positive result and you gave them that advice, how do you then give that advice to yourself? Again, these are tried and true approaches to cognitive behavioral techniques. And then we created an action plan for discussing the peer education and addressing the concerns, wrapped up with self-care encouragement and supporting HST and peer education, and prepped folks for the next session. The next session focused on stigma resistance and coping. Again, we checked in about using HST at home. We did a brief breathing exercise to sort of center people on what is a tough session that is focused on examining some of the negative messages that we receive about our various statuses. So for the women engaged in this study, it could be, as someone who exchanges sex, as someone who's vulnerable to HIV, as a woman. And I should note, and I think somehow it got dropped from one of the earlier slides, and I remember exactly the moment that happened. We enrolled transgender women into this study. All transgender women were assigned to the active arm because we wanted to see if it was feasible and acceptable to them as an intervention. And I'll get to the, punchline. Yes, loved it. So various stigmatized identities were layered for the participants in this. So in the self-care and coping with stigma, we explored barriers to self-care. It was really framed in terms of how do we nurture ourselves? How do we grow? How does our flower grow? And we sort of established where folks were with their stigma coping in terms of denial, acceptance. Had they mastered the ACT technique of diffusion or not? Resistance. Were they actively involved in resisting the type of stigma that they may be experiencing? We talked about baseline coping strategies, and then we introduced in a very kind of light and hopefully playful way, identifying cognitive distortions and presenting cognitive reframing approaches or cognitive restructuring approaches. We, again, built motivation for HST and HIV prevention, and then we wrapped up. The final session, which was graduation, face-to-face, again at the clinic, at the site, the research site, which was a very all are welcome, queer-friendly, woman-friendly, transgender, everybody is welcome vibe at the site. We again checked in about everything. We did a guided imagery meditation, which then, of course, you can take home with you. And a lot of this was new for these participants. We're really used to it, and it seems kind of maybe even hokey to us, but it was not, when we started this project, something that everybody was consuming through social media or other sources. So we then made plans, discussed self-care, self and partner pleasure planning using a cafe menu, completed a health maintenance worksheet, connecting HST to self-care, talked about accessing HST kits, established the reminder plan, and then there was a graduation, receiving a certificate. They made a bracelet that was meant to symbolize what they had learned and what was most important to them. These are activities that are really important to people. It's very easy to just sort of be, honestly, some people might roll their eyes at these types of activities, but they're meaningful. And I'm obviously not the type of person who rolls their eyes because I have my little bracelets that mean things to me, right? But you would be surprised, perhaps, at how meaningful and how effective these cues to actions and reminders can be for people. Okay, so here, if I can find the trackpad, I want to just very quickly, I'll pause and just ask Dr. Darisheva if she has any points that she wants to make that I missed.
No, thank you, Victoria. You have covered everything.
Okay, thank you. Oops, that did not work. How do I press play?
Уважаемые участники проекта ЭГИДА, в этом ролике мы хотим показать вам, как самостоятельно пройти тест на ВИЧ УРЛ+. Необходимо знать, что за 15 минут до начала теста нельзя есть, пить, курить. Для нас важно, чтобы вы чувствовали себя в безопасности. Найдите укромное место и чувствуйте себя защищенным, чтобы вам никто не мешал. Приготовьте тест и таймер. Убедитесь, что срок годности теста не истек. Найдите любую ровную поверхность. Это может быть стол, стул, тумба или что-то другое. Распакованный набор для самостоятельного тестирования состоит из инструкции, тест-системы, флакона с жидкостью и подставки для тест-системы. Расположите инструкцию и подставку для тест-системы перед собой на ровной поверхности. Распакуйте часть набора, где изображен флакон. Откройте флакон с жидкостью реагента. Вставьте его в подставку. Распакуйте вторую часть набора, где изображена тест-система, не касаясь гладкой поверхности прибора. Плотно прикоснитесь к плоской поверхности прибора подушечкой к наружной стороне десны и осторожно проведите один раз между верхней и нижней десной круговым движением. Поместите гладкую поверхность прибора, подушечку в тюбик до касания его дна. Считывать результаты теста необходимо в течение 20 минут, но не позднее, чем через 40 минут при хорошем освещении. Как прочитать результат теста? Если четко выражена одна полоска, результат отрицательный. Проведите тест повторно через 3 месяца. Если вы видите 2 полоски, даже если вторая полоска видна слабо или размыта, то результат положительный. Вам необходимо обратиться в центр СПИД для подтверждения результата. Если вы не видите линии напротив буквы «С» или появилась полоска только напротив буквы «Т», не можете прочитать результат из размытого розового фона или линии нет совсем, в этих случаях тест не работает, он недействительный. Нужно пройти новый тест повторно. Когда тест выполнен, закройте флакон крышкой и поместите использованный набор в контейнер для мусора. Команда проекта ЭГИДА благодарит уделенное время и просмотр данного ролика. На создание этой программы вы могли управлять своим здоровьем и поддерживать его, а также регулярно проходить тестирование на ВИЧ удобным для вас способом.
So that was Natalia Zholnarova, who is the director of Amelia and also a partner on the project and on all of our presentations and papers that have come out of this study, which have been quite a number. So that was the video on how do we do HIV self-testing. This is an example of how we used memes to encourage reframing, a cognitive restructuring approach. Memes are very helpful for how we can engage in trying to shift our fast thinking, our automatic thoughts, which is of course part of the stigma process, internalization of stigma. And so we used them to try to encourage as quick automatic thoughts around reframing a negative thought. So maybe one is my life will never get better because I'm a sex worker. But then when you look at it from a different perspective and you reframe, you say sex work is really hard work and I deserve respect and a decent standard of living and a good life. Similarly, and this sort of tied into our flower metaphor, this is, catastrophizing or thinking that only the worst will happen, what I think will happen if I get a positive HIV test result. But when you look at what's happened from the other angle, you see that beautiful things can grow out of the worst moments in life. We also had the Instagram page for only the active arm participants. This is actually also a video, but it doesn't have sound, but it gives you a sense of how beautiful our Instagram page was. And we had 40 subscribers to the Instagram page. Again, this was developed by some of the wonderful Gersha team members, and I want to pause and let Meruyert tell us. I think this was Denise who developed this, but I want to pause and let you tell us a little bit about who developed this.
Yeah, it was our staff member Denise, and they worked in a collaboration with advocates from Amelia, Yulia and Natalia.
Right. And so about 2/3 of our active arm participants engaged in the Instagram page. And then finally, just to talk a little bit, and this is where I will also ask Meruyert to jump in. As I described before, we used the flower metaphor and the idea of the flower in the environment, which is obviously central to social cognitive theory and how we all approach our work, addressing structural and physical and other barriers and environments. And so there was a phrase that was used in one of the sessions, and I'm hoping that Meruyert, you could expand on the use of this phrase and what it means, and maybe say it in both Kazakh and Russian for the audience.
Yes, with pleasure. So we have this metaphor in Kazakh language. Adam tastai birek guldei nazik. In English, it sounds like human is stronger than a stone and more tender than a flower.
Yeah, so this is a famous saying that, again, reflects that we have in us strength that we may not know, and yet at the same time, we are as vulnerable and fragile as a small flower. And this was meant to, build on this metaphor of us as living, growing entities. Okay, so how did we think all of this would work? I think I covered a lot of this in the beginning, but so again, it was the skills for self-testing. Highest form of learning is what? Teaching. So once you mastered HST and you felt confident in teaching your friends or family members, you built that self-efficacy and you really had mastered the skill. Addressing how we manage the test results, doing it for your peers and yourself. So again, that perspective taking that is so effective in peer education can be turned around and provided to the self, hopefully. Reducing intersectional stigma through the identification of cognitive distortions and doing some very basic cognitive restructuring. It was not CBT. This was not a therapist. These are, one of the facilitators had a psychology degree, but a lot of them, were just experienced facilitators with bachelor's level degrees. So not, a 20-session CBT intervention. Applying the metaphor to encourage self-care and grounding, again, through the mindfulness and the meditation activities. And again, planning, planning to maintain an HIV negative status through condom use, potentially PrEP once it became available, and enhancing peer support through those peer education skills and teaching other peers about HST. So our control arm was a 4-session intervention, obviously. It was time and attention controlled, and it was didactic instruction on self-screening for HIV and breast cancer, self-exam, hypertension and mental health, drug and alcohol misuse and overdose, and then STI prevention, including condom use. Participants in both arms were educated on PrEP, and pamphlets on PrEP, when it began to be scaled up, became available in the waiting area. So this happened in context where things were changing in Kazakhstan in terms of the state response to the epidemic. Participants from both arms were able to access additional HST kits by request, and all test kits included a sticker with contacts for the study in the AIDS Center. Okay, now I'll turn it over to Dr. Darisheva to talk about, I'll quickly just say, obviously, this went through ethical review at Columbia and the Al-Farabi Kazakh National University, registered as a clinical trial. These are our wonderful DSMB members. And so just want to, note that we did all of that. And then Dr. Darisheva will tell us a little bit about some of the implementation components.
Yes, thank you, Victoria. Secondary outcomes in this study included incident STIs, biotesting for syphilis, gonorrhea, chlamydia, and trichomonas. Was conducted at baseline and 6 months follow-up. The study clinical coordinator, a trained nurse, Saltanat Kuskulova, collected blood samples for syphilis testing and vaginal swab samples to test Neisseria, gonorrhea, chlamydia, and trichomonas. Samples were sent to the lab, and the clinical coordinator notified each participant privately within 7 days. A private study physician, Dr. Isahan Rashidov, provided post-test counseling and STI treatment according to the national protocols. I should highlight here, treatment was provided for all participants diagnosed and needed treatment. Please, next slide. Recruitment conducted between November 2022 and August 2023 in Almaty city. We applied several outreach strategies, local nonprofits, outreach workers, social media. We performed venue-based recruitment to saunas, hotels, clubs. We used previous contacts, snowball, and I should say recruitment was the most challenging part of the study. Next slide, please. We built partnership with for nonprofit organizations working with key populations like Amelia, Community Friends, Transdoch Almaty Q. You can see our wonderful partners on this slide. We conducted a series of meetings and trainings to increase their capacity to develop and implement project activities. And as Victoria mentioned before, all our papers and presentation included community partners as co-authors. Next slide, please. And we adopted quality assurance procedures used successfully by our team in prior interventions in Kazakhstan. Fidelity to the intervention was maintained through a multi-steps process. First, we provided comprehensive training for staff facilitator, Dilara Belkesheva, Olga Balabekova, Meruyert Nurkatova, Daniyar Bekishev had extensive experience in facilitating intervention sessions with research participants from different key populations in Kazakhstan. And I think Victoria also mentioned it before. To ensure fidelity of the intervention delivery, all sessions were audio recorded and 25% of them were reviewed by me and supervisor. In addition, we introduced intervision model, which is peer supervision and learning model in order to create a reflective space amongst facilitators for self and peer evaluation of sessions delivery. Facilitators and project director conducted regular intervention meetings to discuss progress, challenges, and address any challenges to fidelity that emerged.
Okay.
Yeah.
Oops, sorry, go ahead.
No.
Okay, so we're going to present the results. I think we'll skip the costing. It's honestly a little underdeveloped. So, and then we can go to questions. So this is our consort flow diagram. I know you're all used to looking at this. As Dr. Darisheva noted, recruitment was challenging, but we did assess over 300 people for inclusion. 163 were excluded, 90 were eligible and willing to participate and did. They were randomized again in a 2-to-1, 60 to the active and 30 to the control. And as with most studies, we had very good sort of retention at 3 months. Things start to drop at 6 months. And just to again note, all women who identified as transgender were assigned to the active arm, and I believe that was 6 women. This is our, I'm not sure, it's hard to tell, but these are the sociodemographics, and this is our assessment of whether randomization worked, and I can tell you that it did. We had similar proportions, or at least not statistically significantly different proportions by sociodemographic characteristics in each arm, as well as by the outcomes in each arm. And this is just showing that those distributions. We did have high proportions of 40% had tested in the last 3 months. So, it was going to be hard to, move that up, but we did. Knowledge of PrEP was about 24% at baseline. High number of sex partners in the last 90 days at about 20. Substance use in the past 90 days was almost 60%. Binge drinking was about 60%, and substance use other than cannabis was just less than half. In terms of what folks had heard about HST, only about half had heard about it. 30% reported having used it, and high proportions, almost all, reported that they would be able to do it. They'd prefer the self-test to read at home, and they would seek help from a clinic if they tested positive. Meruyert, do you want to present this slide?
Yes. So at baseline, we provided testing for 3 STIs and for 4 STIs. 19 women screened positive for syphilis. 13 of them were diagnosed with incident cases needing treatment, and treatment was provided free for all women. 12 accepted and completed treatment. 17 women were treated with trichomonas. 5 with chlamydia, 4 with gonorrhea, 70 were found to have an HIV and enrollment screening. And 0 people were tested positive for HIV during course of study. And this 17, it was self-reports, and I think 3 cases were identified by our clinical coordinator during screening in the field office.
And all were referred to care, confirmatory testing and care, obviously.
Yeah.
Okay, so what did we find? Oh, this got a little messed up in the translation, but we assessed at 3 months and 6 months. And so when you look at the recent testing, so did folks report past 3-month HIV testing in the experimental arm? We see that at 3 months, it was 70%. And in the control arm, well, these, I'm not going to read the percentages because it's actually not right. I mean, not right, but it's not helpful. We did not see a statistically significant difference by arm, but at 6 months we did, with significantly more people in the active arm reporting 4 times at an odds ratio, adjusted for baseline outcomes. Approximately 4 times as many people reported that, with a pretty wide confidence interval. Again, this was a pilot RCT meant to establish preliminary efficacy. So we were not actually powered to find effects, but we did find one at 6 months, which is really nice for the past 3-month testing. And it's 6 months, which is the time that you would want to see that, not necessarily 3 months, because they've just done the intervention. For frequent HIV testing, we see they were 2 times more likely at 6 months, but that this is not statistically significant. And so frequent testing was that they had tested both at the 3-month follow-up and at the 6-month follow-up. And that's really that frequent, that consistent testing is what we are hoping to achieve, period. But HST could really contribute to that goal. And with PrEP knowledge, we weren't able to see a significant change. And this was an intent to treat analysis and logistic regression models. So that's the, big news. It worked at 6 months for frequent testing, which is great. But we also had a significant process evaluation because it was 4 sessions and it had a significant sort of demand. We wanted to make sure that it was feasible and acceptable to participants. So I'll turn it over to Dr. Darisheva.
Thank you, Victoria. So I would like to talk about process evaluation. Session attendance dropped over time in active intervention arm, starting from 100% to 80%. On average, it took 18 days, and range was pretty high, starting from 4 to 63 days to complete all 4 sessions. We plan to complete all 4 sessions within 2-3 weeks. Session attendance was good in general, but we concluded that 2-3 sessions would be optimal. The hybrid model afforded flexibility in delivery for our participants. Participants were enthusiastic about content, and I think Victoria mentioned. Facilitator reported that cognitive restructuring was challenging at times, but that self-compassion and self-care were well received. Victoria, okay.
No, go ahead.
Okay, here you can see participant satisfaction. So as you see on the slide, satisfaction with participating in the study, skills gained, work with facilitators were very high, more than 90%. And we conducted exit interviews with subsample of 15 participants in active arm. And participants found that content was relevant and helpful, shared that HCT was easy to conduct, gave them a feeling of control over their health. They noted improvements in subjective self-worth and compassion for self, most accepted the cognitive restructuring and self-efficacy activities, and noted that it helps them establish a self-care practice. The majority said that peer education was useful and helped them to feel that they could give something to others, which was very important. And I can read supporting quotes. I really like them. My thoughts became a little different. The feeling appeared that I could give something to others. Using the self-test in any place accessible to me, it doesn't take much time. This test is easy to carry out. There were videos where everything was perfectly shown and explained. I later even showed some people how to use this test. Victoria demonstrated this video. AEGIDA helped me to establish myself as a person who will not allow myself to be insulted, and I could take care of myself. That stage in life, AEGIDA taught me to value my body and myself in general. My self-care has strengthened. I had been checked before, but now I realize that this is even more important. These are quotes from our participant. Yeah, during exit interview, many participants expressed a preference for fully virtual intervention, suggesting that remote format would have allowed for greater flexibility. Participants also appreciated the confidentiality, positive attitude, and absence of cameras in the office, which created a safe space for them. They also liked the opportunity to get testing and treatment for STIs. And the most vivid impressions were about creating a bracelet as a part of Stay Negative plan that gave them confidence in health and life. And okay, Victoria.
Sure. I also just want to say that with all of these, with many of the studies, you find that participants are very enthusiastic about the environment of the site where the research is conducted. I've noticed this in multiple HIV prevention behavioral studies. And I think it really speaks to the kind of resources that are sometimes available to us as researchers, as well as the level of training and experience of the folks who are facilitating these interventions, often as compared with the socialization process potentially of healthcare professionals who are working under very different labor constraints and environments. So I think that's important to note. So I think we're going to just very quickly go over the costing data. I mean, we had a costing component. It was led by Dr. Laura Starbird, who's at University of Pennsylvania. We used activity-based costing. She interviewed the project director, but also validated it by study record. So we noted the ongoing monthly costs around the intervention, obviously the active arm, everything, the infrastructure that's required. We can, send this to as evidence of how much things cost. And so, but there was also 1 month in the middle of the intervention where a very detailed costing process was followed to establish greater validity of those assessments, and logs by staff were completed during that month. And then, of course, there were the costs related to testing and treating STIs, which, of course, are significant and not necessarily something that is always accepted in clinical settings. Labor data was used to create the costing assessment, and averages across facilitators was developed. They multiplied the cost per session by 4, and again included those STI testing costs. This is what things cost. Again, this is in Kazakhstan, which is an upper middle income or lower middle income country. And the total cost per participant was about $227. And a lot of that was the supervision and technical cost, about 80%. Attempting to put this in context is hard because it's not just an HIV self-test distribution project. It also included 4 sessions of a behavioral intervention. So we're still working on how we can appropriately contextualize this. But if you do compare it to interventions in other areas of the world where you are only distributing HIV self-test kits, we would have divided the number of test kits that each participant got. So they got 4 just for the 4 sessions. And then the HIV test kit distribution cost would have been $57 US. And so other distribution studies have demonstrated that their range was from, I think, $7 to $54. So we're a little above that, but broadly close to it. But that's not really the appropriate comparison. So we're still working on how best to contextualize that cost. Okay, so before we conclude, we just want to say, of course, we had limitations. We weren't powered to see statistically significant differences by arm, but we did. So we were really excited about that. We wanted to inform powering a larger R01. We did not find women in follow-up who tested positive, so we could not assess our outcome of linkage to care. And HIV biomedical prevention PrEP was generally not available to women at the beginning of the study, so we only assessed PrEP knowledge and changes in that. And although it increased over time, it doesn't necessarily translate into PrEP uptake. So there's a lot of work to do in Kazakhstan around PrEP uptake for women, period, and women who exchange sex and use substances as a subgroup. Obviously, we had self-reported outcome measures, although we did ask for photo validation of HIV self-testing. And I think it's in the notes, we had a very high rate of participants who sent in pictures of their HIV self-test results. But again, our outcome was all HIV testing, not just HIV self-testing. We used computer-assisted self-interview to minimize social desirability, but there are technical issues that come along with that. But despite all of these limitations, or these few limitations, I should say, we think that AEGIDA holds great promise. It had a rigorous time and attention control condition where everybody got HIV self-test kits, so it was not just a matter of access. And we had high session attendance and participant satisfaction. So in some, women who attended AEGIDA were 4 times more likely to test in the past 3 months at the 6-month follow-up than women who attended the time and attention control. It was found to be feasible and generally acceptable. The sexual health management via user-controlled self-screening and self-care was highly appealing to the women who participated. It was acceptable to both transgender and cisgender women. And we did a number of sensitivity analyses. We ran the intent to treat analysis with and without the participants who identified as transgender, just to make sure that it was, you know, robust to that, as that was not consistent with the actual original grant proposal to include transgender women. And we believe that HIV self-testing training and support and engaging peer education to teach others how to do HIV self-testing can increase HIV testing for women in Kazakhstan. Partnering with our community advocates was critical. They were engaged, they were paid, they were included in every step of the process, multiple meetings. They are leaders in this area in Kazakhstan, and it was a great learning experience for our US team. It absolutely has to be centered in all research and program and practice. PrEP linkage is the next step. As it is being scaled up, are women taking it up? We did actually offer a Women in PrEP webinar where Magda Sobieth and Debbie Theodore zoomed in, and we provided some technical assistance, and it was wildly popular. And we actually have an evaluation of that we're working on an analysis of. So that was something that, again, we offered. There's tremendous appetite for women using PrEP, and obviously we have our new trials and our new modalities. AEGIDA will be so in terms of dissemination, Russia is a major source of technical recommendations to the Kazakh Health Ministry. It will be recommended and to them and community partners for dissemination and inclusion in the national plan. And that it be recommended to be implemented via advocacy and NGO organizations. These are our references. This is our contact information. Before we end, we have about 15 minutes for questions. I want to ask Meruyert, do you have anything else you want to say before we go to Q&A?
No, thank you, Victoria. I just would like to add, we welcome partnership with organizations and universities to disseminate AEGIDA intervention in the region and beyond Kazakhstan. So thank you for your attention.
Yes, thank you. I do want to say working with Gersha has been one of the high points of my now 30-year research career, which I started here at our research foundation. So it's just been a pleasure. So we will stop recording and take questions.